The pathophysiology of heart failure: decreased blood ejected from the ventricle, decreasing cardiac output so that the blood pressure may decrease, and the baroreceptors sense the decrease in the pressure so that the central nervous system stimulated, leading to release of adrenaline that may lead to vasoconstriction and increasing heart rate and blood pressure. Adrenaline also causes vasoconstriction in skin, kidneys, and GI tract. Decreased cardiac output also lead to decreased renal perfusion that lead to release of renin from the kidneys, which stimulate to release the angiotensin or conversion the angiotensin to angiotensin 1 from liver, and the angiotensin 1 is converted to angiotensin 2 in lung by angiotensin converting enzyme. Producing angiotensin 2 lead to vasoconstriction and increasing the afterload. Releasing angiotensin 2 stimulate the release of aldosterone that cause sodium and water retention. These are good compensatory mechanisms to increase the cardiac output and the perfusion to body organs. However, this may increase the workload on the heart, causing decreasing in cardiac contractility more and more. Increase in left ventricular and diastolic volume preload, which leads to ventricular dilation, and the condition will be worsened. So that the compensatory mechanism is good until limit. After that, leading to increasing the workload on the heart. It's very important in the management to decrease the workload on the heart, as we said previously, لأنه تحفيز الانجيوتنسين 2 وvasoconstriction والvasoconstriction increasing blood pressure, and this will increase the workload on the heart لأنه زيادة blood pressure وزيادة resistance. So that we have to improve the cardiac output and to decrease the resistance and to overcome the compensatory mechanism that increase the workload on the heart. Providing good counseling, education, regular exercise, restrict sodium, avoid excess fluid intake لأنه البريلود عالي. Medication based on the symptom, provide oxygen therapy, and if there is a pulmonary edema or severe decrease in auto saturation, intubation may be needed. The treatment of choice in severe cases, transplantation. Heart pacing if there are a conduction defects, and nutritional therapy. Angiotensin converting enzyme inhibitors to decrease the workload on the heart, because these medications prevent the conversion of angiotensin 1 to angiotensin 2 بحيث نمنع الvasoconstriction ونعمل vasodilation, decreasing the workload on the heart. لأنه إذا قللنا من resistance عن طريق vasodilation, this will enhance also the cardiac output. Angiotensin 2 receptor blockers, ARBs, also decreasing blood pressure and the vascular resistance. Hydralazine and isosorbent dinitrate, these are vasodilators. Beta blocker and calcium channel blockers if there are no contraindication, if there are tachycardia. Diuretics to decrease the preload, the fluid accumulation in the body. Digitalis to improve the cardiac output. And sometimes there are other types of medication. It's very important for nurses to monitor the intake and output, weigh the patient daily, auscultate the lung إذا في pulmonary edema, jugular vein assessment, monitor peripheral edema, heart rate, blood pressure, skin turgor, and manage any complications.